everybody, and welcome to this week's Data Now and Then talk. I'm very excited. I'm Marika Siebel. I'm an assistant professor in the information school here, and I'm very excited to introduce today's speaker. Stephen Molldrem is a president's postdoctoral fellow at UC Irvine in the Department of Anthropology. His research focuses on the politics of sexuality, HIV/AIDS, LGBTQ health, and health information technology in the U.S. He received his PhD in American culture with a certificate in science, technology, and society from the University of Michigan in 2019. So please join me in welcoming Stephen.
And thanks very much, Marika. Can everyone hear me okay? Okay, cool. Let me know if you can't. So hi, everyone, and thanks for being here. I'd like to get started by thanking Marika, but also by saying thanks to David Rebus, Megan Finn, and Anissa Tanweer for the invitation here. Thanks to James Steinhoff, who helped a lot with the visit, and to Christy Kiefer, who helped arrange the travel. Before I get into the meat of my presentation today, I'll say a bit about myself and my work to contextualize some of the material that I'm going to be discussing. So my talk today actually emerges from research that I did for my dissertation, which I just defended last year in April. I spent over 2 years from 2016 to late 2018 doing ethnographic fieldwork in metropolitan Atlanta, where I worked with the local HIV/AIDS and LGBTQ health communities, predominantly in the safety net. I also conducted fieldwork and document-based health policy research on major developments in U.S. health IT policy, HIV/AIDS policy, and LGBTQ health policy from the period of 2009 onward. So my argument in the dissertation, which I'm now kind of turning into a book and a few different publication streams, is that U.S. federal health information technology policies that were aimed at digitizing the health sector, which largely succeeded, have been key drivers of basic changes in how sexual and gender minorities and people living with HIV are conceptualized and managed in a variety of health contexts, and particularly in clinical and public health contexts. Knowledge that HIV treatment is an effective way to prevent transmission via sexual routes, the incorporation of sexual orientation and gender identity into the national health architecture, and the development of what the U.S. Department of Health and Human Services characterizes as a nationwide interoperable health information technology infrastructure have collectively altered the parameters around which various groups of sexually marginalized people, in which I would also include gender minorities, are conceptualized and served in the healthcare system. I demonstrate how developments in these areas are remaking what I call biomedical sexualities, or sexualities as they become constituted as objects of knowledge and intervention in healthcare, not just drawing on data about, for example, identities and behaviors, but data such as HIV status, history of sexually transmitted infections, other clinically useful information about sexuality. My presentation today comes from that research and a collaboration on new U.S. HIV prevention strategies and programs that actually began this past summer, which is in many ways a follow-up to the dissertation research. So in addition to a few works in progress, I have 2 forthcoming articles from this work that are actually part of case studies 1 and 2 today, one in the journal First Monday, and another co-authored with Anthony K.J. Smith of the University of New South Wales, forthcoming in the American Journal of Bioethics. So today I will be presenting 3 case studies, drawing several claims from each case, and then I will move on to discuss each case's central implication for data science practice, since we're here at the Data Then and Now seminar at the wonderful eScience Institute. And then in the conclusion, I will review where we've been and what I've said, and we'll present a few overarching normative claims to take us into the Q&A. Each of the 3 case studies demonstrates one way that the management of the U.S. domestic HIV/AIDS epidemic has changed over the course of the past decade in some fundamental way. I focus on new ways that public health agencies reuse data that are generated from routine HIV care blood work for public health surveillance and prevention. I'll discuss several programs that are implemented by state and local departments of public health using guidance from the Centers for Disease Control and Prevention, often with the assistance and collaboration of university-based research teams which often include data scientists. Case 1 describes transformations in U.S. HIV data during this new era of HIV treatment as prevention, following again confirmation that antiretroviral treatments for HIV are very effective at preventing transmission and almost totally effective at preventing sexual transmission. In Case 1, I provide an overview of how clinical HIV data have been systematically reused by public health agencies in U.S. in different ways, in different periods since the onset of the epidemic, which has recently experienced a transformation. I examined then how since 2014, routine HIV-related blood tests that are ordered by medical providers for patients living with HIV have been transmitted to health departments, departments of public health, and reused to inform surveillance and prevention under a CDC-supported program called HIV Data to Care. HIV Data to Care programs reuse data from routine clinical HIV blood work that are electronically transmitted to departments of public health by laboratories that conduct tests to identify and contact people living with HIV who are identified as likely having fallen out of care, or whose critical biomarkers such as viral load or CD4 T cell count indicate that they might benefit from more support services or could be infectious to others. I describe how HIV Data to Care programs are designed to support treatment as prevention by bringing people back into care through direct outreach who have fallen out of care. So because these programs are, this is kind of going to be a drumbeat throughout the talk, because these programs are conducted under public health law, the data reuses that facilitate them are done without any patient consent, and no affordances exist for people living with HIV to opt out of participation in them, and that's going to be the case in Case 2 as well. In Case 2, I build on Case 1. I will describe another, newer way that clinical HIV data, these clinical HIV blood work, are reused by public health agencies to support treatment as prevention. Case 2 specifically considers the application of open source software tools that were developed to conduct research on HIV viral evolution, a practice that's called HIV phylogenetic research, directly into public health surveillance and prevention. I focus specifically on two pieces of open source software that are used for HIV phylogenetic analysis. The first is called HIV Trace, and the second is called PhyloScanner. These software packages were developed by university researchers to analyze data sets that contain a specific kind of HIV data called HIV genetic sequence data. HIV genetic sequence data are often also called molecular HIV data. These data, these HIV genetic sequence data, are generated when clinicians order antiretroviral drug tests for patients living with HIV, thus helping the provider prescribe appropriate antiretroviral medications. In the research and public health context, though, HIV phylogenetic analysis reuses these HIV genetic sequence data in order to identify what are called transmission clusters, or groupings of people with strains of HIV that are closely related at the viral genetic level. This is possible because, like other viral pathogens, HIV evolves over time within individuals. Therefore, each HIV genetic sequence is actually unique to an individual's own HIV. However, the evolution of an individual's HIV happens gradually after a person becomes HIV positive, becoming increasingly unique to them over time. This means that in the period shortly following transmission, individual strains of HIV are actually more closely related at the level of viral genetic information. So phylogenetic analysis at the population level has allowed researchers and public health practitioners to infer information about recent transmission in groups of individuals by comparing the genetic content of their HIV. I have to emphasize, this is not human genome data, this is viral genetic data. So genetic data about people's HIV, not about the people themselves. The use of open source software tools designed for HIV phylogenetic research in public health epidemiology is often called molecular HIV surveillance, and the use of molecular HIV data in this cluster detection modeling in direct prevention outreach to individuals is called HIV cluster detection and response. And notably, in 2019, HIV cluster detection and response programs were announced as the fourth pillar of ending the HIV epidemic, a plan for America, which is a new federal strategy. So much like Data to Care, which I'll talk about in case 1, cluster detection and response programs are designed to identify people living with HIV who are out of care or who are perceived to be more likely to transmit, and then to bring them back into care to support treatment as prevention goals. In case 2, like I said, I focused on open source software tools that can actually be used to infer the directionality of transmission within clusters or from one person to another. So stakeholders in the HIV community have cited this as a major concern, particularly in the present social context where even alleged HIV transmission is often criminalized in many jurisdictions. In case 3, I analyze a project in South Carolina that's currently being undertaken by university researchers in partnership with various branches of the state government. The project utilizes what the study team describes as big data science methods, machine learning, and predictive analytics to assess approaches to HIV prevention in the state, drawing on what the study team characterizes as, quote, a comprehensive database of all people living with HIV in South Carolina, unquote, the HIV surveillance system in the state, along with other data that are held by the Department of Revenue and Fiscal Affairs that actually takes the HIV surveillance data and centralizes it with many other sources of information from different departments of the state and local government. So the project that I'll talk about in case 3 applies a framework to the data that are designed to predict which people living with HIV in South Carolina are predisposed to fall out of medical care based on past behaviors that are contained in this data set. So taken together, these 3 cases will provide us with an historical overview of uses of clinical HIV data for public health in the U.S., a discussion of current and emergent practices, and then an overview of some likely emergent future directions in HIV prevention. I conclude, as I said, each case with a discussion of its implications for data science, since we're here at the eScience Institute, and at the end of the talk, I will present some normative claims to take us into the Q&A. So now we'll move on to case 1 on HIV data to care, which I'll begin with the history of public health uses of clinical HIV data in the United States, or the history of U.S. HIV surveillance. So in the United States, since the 1980s, all state departments of public health and some large local and city county departments of public health, such as New York, Chicago, Seattle, Los Angeles, have operated infrastructures that are called HIV surveillance systems. These are very complex data infrastructures. This is a diagram of the state of Georgia's HIV surveillance system that was given to me by an interlocutor at the Georgia Department of Public Health while I was doing my dissertation research. So I show this to you to demonstrate the complexity of the infrastructure itself. Don't try to understand it all. It's basically just showing there are a lot of inputs and a lot of outputs. Here are the electronic lab reports we're talking about. This is where new diagnoses come from, and then you can see on the right side how the surveillance system disseminates information through, for example, publications and annual assessments. But don't try to understand the diagram. I present it to rather show us how complicated and complex HIV surveillance systems are. And in fact, that's how practitioners work with these sorts of diagrams. This was taped above her desk when for the entire time I was doing research in Atlanta, and she would look at it to kind of help her, who worked with the surveillance system, make sense of what was actually going on. But state and local HIV surveillance systems are operated using guidelines from the Center for Disease Control and Prevention. HIV surveillance systems at base maintain a census of all people living with HIV in their jurisdiction. Health departments also regularly share de-identified surveillance data with university-based researchers to collaborate and to produce publications. That's what we'll be seeing in case 3, but it's actually peppered throughout this entire case, this entire talk. Since 2008, following a series of pretty controversial policy battles, data held by jurisdictional HIV surveillance systems have been connected to people's first and last names. So supported by mandatory reporting requirements set by state and federal public health laws, HIV surveillance systems have historically only been used for epidemiological purposes. That is, things like tracking major events, such as new cases of HIV infection or a person living with HIV moving to a state from somewhere else, or cases of AIDS-defining conditions like Kaposi sarcoma, or progression of cases of HIV to AIDS. However, since the issuance of a 2013 presidential executive order, followed later that year by CDC guidance sent to health departments, all jurisdictional HIV surveillance systems have been required to collect routine HIV-related blood work data from tests that are ordered by clinicians for patients living with HIV every time the patient goes to receive HIV-related medical care. So these data are used to facilitate what is often characterized as real-time monitoring using a framework called the HIV care continuum. The care continuum is a model for tracking rates of engagement in HIV medical care and rates of HIV viral suppression in a jurisdiction. HIV viral suppression, which you might have heard called undetectability, means that an individual has effectively zero risk of transmitting HIV sexually and highly reduced and very reduced risk via other routes such as needle sharing, and it's the basis, viral suppression is the basis for executing treatment as prevention strategies in the management of HIV. People living with HIV ideally receive these routine blood work consisting of viral load tests, which measures infectiousness and disease progression, and CD4 T-cell tests, which are a measure of immune health at least every 6 months, ideally. Data from these routine blood tests ordered by clinicians for patients living with HIV are then reported to surveillance systems electronically by laboratories that conduct the tests. This is an HIV care continuum for the Atlanta metro area produced by the Georgia Department of Public Health. It reports rates of engagement in care and viral suppression based on clinical lab reports. In 2014, 1 year after surveillance system began collecting these routine clinical lab data, CDC released guidance that would fundamentally change HIV surveillance data again, and in an even bigger way, I would argue. This program is called HIV Data to Care. So at base, Data to Care directed state departments of public health to reuse these HIV surveillance data for direct prevention purposes, such as reaching out to individuals by phone, by mail, and at their homes if they were determined to be out of care. To emphasize, prior to 2014, in the vast majority of jurisdictions, HIV surveillance data were only used for epidemiology, analysis, and planning. What Data to Care guidance did is it brought down this firewall. It allowed HIV surveillance data to be sent out of the surveillance system, which would only previously receive data. It allowed these surveillance data to be sent out of the surveillance system to prevention departments in order to locate people who were likely out of care and then bring them back into care, again, to support the treatment as prevention strategy. Reuses of data from routine blood tests ordered for patients living with ordered for HIV patients by medical providers for direct public health prevention constitutes the most significant transformation in uses of HIV data in the United States since the onset of the epidemic in the 1980s. Using Data to Care guidance, as I'll describe in a moment, if a person living with HIV does not report consistent blood work to their jurisdictional surveillance system, or rather if the laboratory doesn't report it, or if they report suboptimal test results, departments of public health are encouraged to place these people living with HIV on what are called out-of-care lists, and to use these lists in direct prevention outreach to individuals. They can also contact their doctors and to individuals suspected or reported sexual or needle-sharing partners. This is a logo for the Georgia Department of Public Health's HIV out-of-care watch list, or the OWL, which the agency has somewhat strangely to me chosen to represent as a watchful little owl perched there in the O. Data to Care itself is a 4-step process that creates what CDC calls a feedback loop to surveillance. I recommend an essay by Martin Holt on HIV surveillance if any of you are interested in this. He's talking about different systems, but he also adopts this notion of the feedback loop, as does CDC. The first step in Data to Care is constructing the initial HIV out-of-care list using clinical data, using clinical lab data. The second step to Data to Care is refining and enhancing the HIV out-of-care list with other sources of data. The third step in Data to Care is conducting outreach and then providing services to people who are on the lists, so direct outreach to persons. The feedback loop to surveillance closes in the fourth step when the HIV surveillance system receives data from blood work indicating that an individual has engaged in HIV-related medical care and has had a viral load or